Let's talk about primary biliary cholangitis. It is characterized by portal inflammation, necrosis of cholangiocytes in small and medium-sized bile duct. It is more common in females than males, and the ratio is 9:1. Median age of diagnosis is 50 years. It has four distinct stages of disease progress. The first is chronic non-suppurative destructive cholangitis. It is the necrotizing inflammatory process of portal tract. In primary biliary cholangitis, medium and small sized bile duct infiltrate with lymphocytes and undergo duct destruction. Generally, a number of bile ducts is reduced and there is proliferation of small bile ducts. Eventually, periportal fibrosis become bridging fibrosis, and finally cirrhosis, which is micro or macronodular, may develop. So, in short form, there is immune mediated injury of bile duct. Secondly, the patient develop ductopenia. Thirdly, the patient become fibrosis. The hepatic fibrosis developed, and lastly, liver becomes cirrhosis. Most patients are asymptomatic, but few patients may present with fatigue, which is out of proportion to either severity of the liver disease or age of the patients. Some patients are also presented with pruritus. But if the pruritus developed before the onset of jaundice, then it indicates poor prognosis. Patients also may develop hepatomegaly, splenomegaly, ascites, and edema. And other features include hyperpigmentation, xanthelasma, xanthomata, and bone pain due to osteoporosis. Lab findings include increased gamma glutamyl transpeptidase in LFT, increased ALP, and mild elevation of AST and LT, increased IgM. And if the patient develops cirrhosis, then hyperbilirubinemia also developed. Patient may also have thrombocytopenia, anemia, and leukopenia. And up to 10% of the patient also developed autoimmune hepatitis, and this is called overlap syndrome. It is diagnosed by AMA, which is positive in 90 to 95% patients. And the full form of AMA is antimitochondrial antibody. Cholestatic liver enzyme abnormalities also developed, and other tests of primary biliary cholangitis is SP100 and GP210. If the patient is AMA negative, but there is a strong suspicion of primary biliary cholangitis, then liver biopsy may consider, because AMA is negative in 5 to 10% of the patients. And the treatment include ursodeoxycholic acid, which is given at a rate of 13 to 15 mg per kg per day, which shows improvement in both biochemical and histological features of the disease. Some patients may develop diarrhea and headache due to this ursodeoxycholic acid side effect. But if the patient is not respond with ursodeoxycholic acid, then we may try obeticholic acid. The pruritus part is managed by antihistaminic agents, narcotic receptor antagonist, and rifampicin. There is an increased incidence of osteopenia and osteoporosis in those patients. So it is necessary to do bone density testing, and patient may need vitamin D and calcium supplementation. Sometimes patient may also need bisphosphonate therapy.